Time for this important session, and I'd like to introduce Dr. Richard Kidd, AMA Council of General Practice Chair, who will run this next session entitled Aged Care, Improving Clinical Care in an Era of Financial Constraint. Welcome, Richard.
Thank you. Good afternoon, everyone. I'll just get myself organised here. So I suppose in the first place, many of you may know who I am. I'm a GP who's been working in Brisbane for some 30 years and doing a lot of aged care during that time. I was the last chair of the AMA Healthy Aged Care Committee, or Ageing Committee rather. I was the inaugural chair of the RACGP Specific Interest Group for Aged Care. I am currently on the Minister's Aged Care Clinical Advisory Committee. I suppose to set the scene a little bit, as everyone would know in this room, we are seeing more and more older Australians. The demographics are changing, but it's particularly in aged care that this is becoming more acute, where we're seeing many more people being admitted much sicker, much older, much more frail, much more complex. And we have seen this coming, and the AMA has been very strongly advocating in this space for a long time, trying to get proactive planning around workforce, training, research, and in particular things like the interfaces between general practice, aged care and the acute sector, trying to improve transfer of care and communication with mixed success. There was a 5-year renaissance in the 90s that was an exciting time when we had the GP Aged Care Panels Initiative, and that saw a lot of really great work happening. We were getting clinics, examination rooms into all of the aged care facilities. We were getting things like clinics or proper rounds set up where there would be a nurse that would go with the GP on their rounds. But that was a brief renaissance, about 5 years. Since then, things have gone backwards, and we've lost many of the wins that we had. Not all of them, thankfully. But the examination rooms, the consulting rooms have pretty much gone. There, by and large, isn't an experienced registered general nurse that will do a round with a GP in the aged care facilities anymore. Even access to the computers is tricky, certainly Wi-Fi. One of the new aged care facilities I go to that I really help them transition a whole lot of new admissions from another aged care facility. When I asked for Wi-Fi, I was told that's not made available to contractors. So I think we're seeing somewhere there with the tradies. At least because of the AMA's hard-fought advocacy, we have still retained the Aged Care Access Initiative, which is a very important thing, not just monetarily, but symbolically for those GPs that do aged care, because it's an area in which you can very easily feel unappreciated and unsupported. And if the Aged Care Access Initiative had gone, we would have seen a lot of disaffected GPs walking away from doing aged care. And we know that from the surveys that we've done, which we'll refer to a bit later in the question and answer session. We have, through our advocacy, I think, been a major player in getting the Aged Care Quality and Safety Commission and having a chief clinical advisor who is a doctor. We've had significant input into the Royal Commission with the Aged Care Quality and Safety Commission, and in the last 10 years, despite all the work that we've been doing, we've seen a significant reduction in the ratio of registered general nurses to the aged care workforce, dropping by a third. And we've also seen the allied health providers halved in the aged care area. So a question I'm going to put to each of our panellists, who I'll introduce in a second, is what's the one thing that you would most want to change to improve clinical care in the aged care area? And for me, I suppose it's really, as was reflected in our survey of our members, I want to see more registered general nurses on the floor with good clinical skills, who are good at early detection of clinical deterioration and good communicators. So we've got a great panel to help us work through this today. And so first of all, I'll introduce Janet Anderson. She's a career public servant who for the last 20 years has held a range of executive positions at the Commonwealth, state and regional levels, working in areas of health and aged care policy, strategy and planning. And after stints in the New South Wales Department of Health, Commonwealth Department of Veterans Affairs and the Commonwealth Department of Health, Ms Anderson took up the position of Deputy CEO and then Acting CEO of the Northern Territory Department of Health. Immediately before her appointment as the inaugural Commissioner of the Aged Care Quality and Safety Commission in January this year, Ms Anderson was Chief Coordinator with overall responsibility for leading the Northern Territory Government's response to the Royal Commission into the protection and detention of children in the Northern Territory. In 2009, Ms Anderson was awarded a Public Service Medal for her contributions to health system policy. So I'll just get myself organised again here. And I think I forgot to say at the beginning that she is the Aged Care Quality and Safety Commissioner. And Ms Pat Sparrow, who's CEO of the Aged and Community Services of Australia, is leading this organisation towards a new era in challenging times. And she's got significant experience and expertise in social policy leading, as an innovator with expertise in stakeholder engagement. Professor Andrew Robinson is co-founder of the Wicking Dementia Research and Education Centre, and this was established in 2008, and he's an innovator in dementia care practice, aged care workforce development, health professional and online dementia education, and translational research in aged care. And he's received over $25 million in research grants and has more than 100 peer-reviewed publications. And Annie Butler is the Federal Secretary of the Australian Nursing and Midwifery Federation, and she was formally appointed to the role in June 2018, having served as the Assistant Federal Secretary since 2014, and following years of experience in the clinical, professional and industrial areas of nursing. She's a registered nurse with more than decades experience in working in public hospitals, the community and on health education projects, and a further decade working in research and education. She worked on the New South Wales Nurses and Midwives Association for a further decade as a professional officer, organiser and lead organiser prior to moving to the national position of the Assistant Federal Secretary. Dr Chris Davis is going to be joining us by Skype, which is a good thing to be doing in a session here, because this is one of the things that aged care is looking at doing. There's a lot more teleconferencing and using modern technologies to assist in delivering high quality clinical care. Chris is a geriatrician with an MBA. His other roles include having been departmental head in a major academic hospital, Health District CEO, AMA Queensland President and Assistant Minister for Health. And I would hope many in the room would remember how he stood up for what was right rather than a political career. His interests included improving accessibility, appropriateness and affordability of healthcare, assisted by technological advances. And as per Cicero's De Sinecure, Chris lives on his farm and is working on the pursuit of agriculture to his 100th year. So we come now to the question that I posed to myself at the beginning, which is, what is the one thing you would like to change to improve clinical care in the aged care setting? And we might go in the order of my introduction. So, Janet.
I'm going to preface my comments by making a statement that I'll probably be talking about this subsequently. There you go, now you can hear me. I've just said that the one thing that I have identified, which I think is going to make a significant difference to clinical care in aged care, are the new standards, new quality standards, which are being introduced from the 1st of July, which is just around the corner. And for those of you who aren't aware of the new standards, they are a very material and significant change from the 20-year-old standards which are currently in place. And their implementation by aged care providers will lift the focus, the emphasis the attention which is paid to person-centred care, including clinical care.
And Annie?
Yes. Thank you very much, and thank you for having us here today. The one thing that we would suggest from the Federation's perspective, and you echoed it in your opening there, Richard, is to get the staffing levels right. And we're talking about all staffing levels, including allied health, but from our perspective specifically, about getting nurse and care worker staff levels right, and we mean both numbers and the skills mix right. And I think I'm getting the opportunity to talk to you more about that in more detail.
Andrew?
So mine, thank you for having me. I suppose mine might be a little left field. What I think would be the first thing I would want to do is do an audit of all medical, nursing and allied health curriculums in this country, and to look at how well they address the issues of comorbidity, chronicity, ageing and dementia, and how they conceptualise and address those issues in their curriculum, and also how they configure, how much interprofessional engagement there is between the various student groups that is meaningful and actually very engaging. Because the evidence suggests that our undergraduates are educated in silos and largely by acute care clinicians, whatever the discipline, and that they graduate with a very limited understanding of chronicity, of multiple morbidity, of ageing and of dementia. And arguably, and I'm not alone in thinking this, that there is an element that they graduate very often needing remediation. Now, there will be exceptions to this, but that's what I would like to change. I would like to bring the curriculums into the 21st century to more adequately address the problems and the issues that students as graduates need to face.
Pat?
It's terrific that we're having an engagement with aged care providers and the AMA. I think that's really important. Just a little bit about ACSA before I talk about what I think is perhaps one of the changes, and I'm sure there are lots of things that we want to do to see aged care be of the very best quality that it can be. Aged and Community Services Australia is a representative body and also a membership body, and we represent not-for-profit aged care providers right around the country who provide residential aged care, home care, and housing and retirement villages for older Australians. One of the things that we are particularly focused on at the moment is in terms of how we improve the experience of healthcare for people, is that we think that when older people come into residential aged care, they don't have the same access to primary health and to the health system that other Australians living outside of residential care have. So we do think there are some issues that need to be addressed around making sure that people have access to primary health care, and that the system actually supports health professionals and aged care providers to work together to actually deliver the best quality care that we can.
Thank you. And we've got Chris online.
Yes, thank you. Thank you very much for the invitation, and I hope you can hear me all right. Yeah, I'd like us to just take a quick journey back. Some 30 years ago, one of the facilities that I worked with as Director of Geriatrics at the Prince Charles Hospital was Eventide Nursing Home at Brighton, about 140 places there. And at that time, there was a full-time medical superintendent, a full-time matron, a whole team of registered nurses, very dedicated, expert and long-standing, as well as enrolled nurses, allied health, wardsmen, and there was no doubt at all that back then it was relatively easy to provide high-quality clinical care because you had this team who'd been trained to provide it, who were well supported to provide it, and of course there were also a team of general practitioners who were actually part of the staff. They were on the payroll, and between them they provided a 24/7 roster. And I think the pendulum in the neoliberal era has gone much too far the other way. And now we're really talking about facilities that are there to provide personal care. And if you're lucky, you can get some reasonable health care in the midst of that. But contrast that, as I say, to 30 years ago, when there was a recognition that healthcare was intrinsic to providing a good quality of care, a good model of care. And we need to somehow get back to what we saw 30 years ago if we're going to be realistic about improving the quality of healthcare in residential facilities.
Agreed. Thank you, Chris. Now, with the next part, I've got some questions that I can ask the panellists, but at any stage, if anyone wants to ask any questions or comment on the discussion to date, there are two microphones behind you, numbered 1 and 2, and if you line up behind those microphones, I'll get to you. And we've already got someone to kick the ball off before I even start myself. No? You're adjusting them. Okay. Well, while someone's moving there, I'll just start by saying the AMA conducted an aged care member survey in 2017 with over 600 responses. Respondents prioritised availability of trained and experienced nurses in aged care facilities over Medicare funding for themselves. And I touched on it before, and I'll just share briefly an experience from about 30 years ago when there was a little old lady, very frail, chronic obstructive lung disease, bunch of other problems, basically was not an anaesthetic candidate at all, and she had gangrene of the foot. And I basically removed that foot in the nursing home, divided it back to viable tissue, and she survived that procedure very well and went on to live to be about 106, and she had good quality of life up until she was 105 minus the foot. I did that with the assistance of two very experienced general nurses who were probably in their mid to late 40s, and the whole procedure went very, very well. Now, if I go forward 30 years to one of the lovely new big buildings that looks really schmick, on this occasion, a lady came back from hospital having an above-knee amputation, was very, very sick, and basically the whole back of her, what was left of her thigh, was rotting away, and it really needed to be removed as much for comfort as any other reason. And on this occasion, there wasn't a nurse to be found, and the person who assisted me was a personal carer, 18 years old. I think she had probably been in the job for 3 months, and she was clearly traumatised. She was at the point of vomiting several times. She was shaking, sweat was pouring out. She was looking really distressed, and I spent about another hour debriefing her afterwards because it was such a traumatic experience for her. It shouldn't have been that way, and this is 30 years later. So Annie, the ANMF has been campaigning to regulate aged care staffing ratios. Could you describe the research ANMF has carried out to develop the hours of care older people need and the staff makeup to what we need for being able to do it cost effectively?
Sure. Thanks very much, Richard. And unfortunately, the story you just told is something that we hear repeatedly. So we're looking at a system that it doesn't have a clear legislative requirement or even an evidence-based requirement for staffing, and I'm talking specifically about residential aged care. So it's therefore actually quite difficult for providers to make those decisions, we think. And what seems to have become the norm is that people benchmark staffing against supply. So it's just what's sort of supplied in the residential aged care facility rather than staffing assessed against actual care needs. So what we just thought we needed to do was then conduct some research that actually looked at what are the care needs of residents in residential aged care, what are the nursing and other care interventions required, and which personnel should be doing those particular interventions. Because across the system now, we're looking at, we might have a ratio of 1 registered nurse to 60 residents. We might have 1 to 150. I've heard of 1 to 200. I've heard of 1 to 300, or I've heard of none. 2 care workers perhaps being left for a night shift, particularly night shift. in those circumstances, there is very little option for people to respond to deteriorating patients, to urgent needs, all of those sorts of things. People get shipped off to hospitals. Many of you might not know about a lot of the insides of residential aged care. Many of you may, but also a number of you are going to be seeing the impacts in your public hospitals, in EDs, and then potentially blocking up wards, etc. We hear that from our members, nursing members, working in the public system. So I'll try and do this fairly briefly. Obviously, the ANMF's been advocating for mandated ratios. That's our public message. The research that we conducted, which we released in December 2016, actually takes a more sophisticated approach to what we need for staffing in residential aged care. What we did was looked at the care plans of an average group of residents across the country. We identified that there's 6 typical resident profiles. One could actually argue that those profiles, given that it was 2016, there could have been some shift in those profiles, but 6 typical profiles, each requiring a certain number of hours of care per day, ranging from 2.5 hours of care to 5.5 hours of care. Given the population base that we had across residential aged care at the time, that reached an average of 4.3 hours of care per day, and the current staffing hours benchmark is around 2.8. So there's about an hour's gap. That's consistent with international research evidence. It's also consistent, research around what the hours should be, really, and also consistent with, I don't know if any of you are aware of the work that was done by the Aged Care Workforce Strategy Task Force, which also identified about an hour's gap in care. Then what we looked at across those resident profiles, and I won't go, if anybody wants to look at the full reports of the research and anything else I talk about, they are on our website. But what we then looked at, we timed the interventions, how long do they take, and who should be doing them. And across those 6 resident profiles, with those range of hours of care, we identified that it should be given by 30% registered nurses, 20% enrolled nurses, and 50% care workers, personal care workers. What we're looking at, the full implementation of that, requires an additional sort of, 80,000 workers overall. So it's not something that would happen overnight. We suggest that it would take at least 5 years to try and implement the full outcomes of the research. As Richard indicated earlier, currently the makeup of the workforce is about 14% registered nurses, it's about 70% care worker, and the in-between for enrolled nurses and the enrolled nurse section varies widely across the country because some states they're close to non-existent, and some states, for example, Victoria, has a strong, healthy enrolled nurse workforce. So that's actually the model that we're trying to put forward. It is the only evidence-based staffing model for residential aged care currently in the country. We're not trying to suggest it's the only one, or it's the one that must be used, but we're just suggesting that it's the only one we have currently, but others could be developed along the same lines. And we're also not trying to suggest that getting staffing levels and skills mix is the only solution for aged care. We think there are many reforms needed. We just believe that quality and improved clinical quality in aged care won't happen without getting that right. Did you want me just to move straight on to how we looked at costing it, or?
We might come back to that because it looks like we've got a lot of interest. So, if anyone's particularly keen, they could always approach you afterwards, I guess.
Yes,
but,
of course.
So just before we move to Dr. Hamilton, Pat, would you like to comment on the staffing ratio debate? Would you consider supporting staff ratios if they reflected the level of care need of the residents in the individual aged care facilities?
What aged care providers and the aged care sector is saying is we're in absolute agreement that we need more workers in aged care, and we need more workers who are right fit is the terminology that we like to use. People who want to work in aged care, people who've got the right skills, people who've had the right training, but that might be some of that might be on-the-job training and some of that might be before. The key thing is that we've got people who want to work in aged care, who like working with older people and are right fit. So we're absolutely agreed that there needs to be more staff in aged care. what we think we do also need in that, because residents' care needs change over time, and it is true that we're seeing an increase in residents coming in at an older age with more complex healthcare conditions, and that needs to be factored into all that we do. But we also think we need flexibility within that to be able to manage what needs there are. Providers are required through the current accreditation system and commission to have the right level of staff and skills mix to support the residents that they have, and there are of course care planning and a range of planning arrangements in place to make sure that that's the case, and providers are assessed against that by the commission. But I do want to be clear that we are supportive and do agree that there needs to be more staff in aged care, and we need to have the flexibility with more staff for us to be able to have more staff. And it's important to point out that there are benchmarking studies which are showing that the hours of direct care have been, of nursing direct care and of direct care generally, have been increasing. Not disputing what Annie's saying, but there has been some increases in that over time, and that's really important to note. It's also important to note that the aged care workforce, as many of you would know, is quite broad. So there are nurses and personal care workers, but there are also hospitality staff, activity coordinators across the full range, and we need to look at staffing models that support all of that. I think Annie's referenced the Workforce Strategy Task Force, of which I was a member. It did some terrific work looking at what the workforce challenges were right across the industry, and came up with 14 recommendations, which we now in the aged care industry are establishing a workforce council to start implementing that report and look at the workforce most broadly. One of the things that strategy did was to actually look at the broader workforce, so the staff who are in aged care, but also allied health professionals, yourselves as GPs and doctors who come in, who really form part of making sure that an older person in residential aged care is getting the care that they need. And we would say that for us to have more staff in aged care, one of the things that the Workforce Strategy Task Force did talk about was, in terms of the funding, there's not really enough funding in the system for us to be able to deliver one more hour of care. So one of the things that we would say, we support more staff, there's going to need to be more resourcing and more support for that to be able to be achieved.
Janet, is this an area the Commission would be interested in looking at around the standards and how they're met, or any other aspect of it?
Yes, we don't engage with the notion of staff ratios because it's not currently part of the policy setting. So my Aged Care Quality and Safety Commission is bound essentially by legislative provisions, principles and so on, subordinate legislation. So we don't come directly at staff ratios, but we absolutely, in our quality assessment and monitoring work, and also in resolving complaints about and with providers, look at staffing levels and whether they are fit for purpose. As everyone would appreciate, and as Pat was alluding, and I think even Annie, each facility, let's stay with residential aged care, has a particular and probably unique configuration of care recipients at a point in time. Those care recipients change over time, and the needs of individuals change over time. So it's not a set and forget issue, it is calibrating the staffing complement to the needs, the presenting needs of the consumers at a particular point in time. And when my audit teams go into a residential service and have a look at how they're going against the standards, one of the areas where we do look very closely is there a sufficient level of capable, well-trained or adequately trained staff to deal with the presenting needs of these residents at this time.
Thank you. Andrew, do you have any comment?
Look, I think that it's a complex issue, and I think, as Annie said, getting staffing numbers right is a core issue. It's not going to make it necessarily better. Just with respect to Janet's comment, I mean, our work, and I'll talk a little bit later, shows that there are profound knowledge deficits among staff in the aged care sector, which in health professionals originate out of their undergraduate programs and then out of their postgraduate training. So we're not equipping the workforce. We've got a lot of really good people who have strong volition but are not equipped. And that's exactly the same in the RTO. And the evidence that we have for this is pretty unequivocal. And it means that you get very dysfunctional environments where you might have clinical lead nurses, for example, who know less about dementia than care workers who have educated themselves, and both of whom may know less about dementia than a family member who has little opportunity very often to have any sort of input into care. So I think knowledge and training is another one of those core issues that we have to address.
Agreed. Chris, do you have any other comments?
I would just endorse what Andrew said. I mean, if you look at the complexity of the human body at its best, and then you add frailty across all systems to that equation and functional failure, it takes decades really to begin to understand what you're looking at and to understand the appropriate interventions, whether they're biological, psychological, social, ethical, and you do need that expertise there. You can do it badly, but the consequences of doing it badly are not good. And, I reflect back again 30 years, no one, to my recollection, was asking for physician-assisted suicide 30 years ago. And now, in the latest ABC opinion polling, 90% of Australians are asking for access to physician-assisted suicide. So, I mean, that deficit in terms of skills is very apparent. And, of course, the bulk of that day-to-day comfort for a person in residential care is provided by the skilled staff on the ground. And you absolutely need that level of expertise to support people. You can't just have it coming in periodically from agency nurses and so on. And you certainly can't have it coming in from people who are just here on a migrant visa to provide personal care assistance. I mean, we really do need to wake up to the reality of the skill set that is required in residential care and to be honest about doing it properly.
Thank you. Agreed. Steve Hamilton.
Thank you very much, and thank you for the session. I think you've set the scene very well, and thank you, Chris and others, for pointing out about the frailty, the chronicity, the complexity, the multimorbidity and the challenges there. I'm interested in, and I guess it's a bit of a diversion from what we've just been talking about, the medication management in residential aged care. When I was AMA president, we went to a lot of work to put together a residential medication management chart, which could be used by the dispensers as well as the prescribers to get PBS prescriptions. And I reflect that in 1995 I bought a computer to do prescribing in my practice, and I spoke to one of the major aged care providers a couple of days ago and asked them about electronic prescribing in terms of accuracy and transcribing errors and transmissibility. I mean, we know the transitions of care are a huge challenge, and that major provider, a national provider, ditched the computer 3 years ago, went back to written medication charts. And I asked them whether they were using the National Residential Medication Chart. The answer was no. The GP's got to write the prescription to go with the order sheets. I rang the pharmacy and said, how does that work for you? It's terrible because there's owing scripts constantly. What happened to the National Residential Medication Chart? And I guess what happened, is there an e-residential medication management chart on the policy table? Because I think we need both.
Who would like to take that?
I mean, I guess there are a range of initiatives to try and look at how we become better technologically enabled in aged care. And I know there's been various initiatives at various times. Some of them have lasted and some of them haven't. So we do have in aged care, there's often small initiatives that are in place for a little while that don't hold. So one of the things that we do have to look at is how we actually improve our infrastructure and what's needed to do that, and how in fact that very issue that you're raising, how we can as aged care providers work across the health system, and that interoperability and capability between aged care and the health system and pharmacy is increasingly important.
Jen?
Pat was saying, I might. The Commission received an amount of money through the most recent federal budget to establish a clinical pharmacy unit specifically to look at the ways in which we might provide guidance and support to the aged care sector in relation to medication management. I think there was some wind in the sails of that initiative in all of the recent discussions around so-called chemical restraint or pharmacological restraint, but the broader issue of medication management is clearly one that needs a closer look, and I'm sure Pat is of the same view. Certainly as my Chief Clinical Advisor goes about establishing the clinical pharmacy unit within the Commission, at least for the period for which we have funds, I expect that we will be engaging much more closely with that particular initiative, which was the subject of a brief conversation I had with her just 2 days ago.
Starting to do some work at looking at aged care across the board and how we actually have systems right across the board that support those things more easily.
Andrew?
One of the capabilities that appears to be we struggle with is how to address polypharmacy. And so the notion of deprescribing, and there seems to be a profound lack of confidence among GPs, among nurses, around actually implementing processes that will support deprescribing. So that's a real key educational front I think we need to address in the context of getting on top of the issues that we have with medication management.
It's not just the staff. I was recently fired by one patient's son who was a doctor because I was actively deprescribing and he didn't want that to happen. So,
and that's correct. So there's it, and this comes down to, again, how do we engage family members in the whole process of care so that they become active participants in care decision making, which means they're not just told what happens, but they are brought along that journey.
It's really true and very
with the staff. Because, yeah, you're right. You're going to take drugs off my mum? What are you doing? You're trying to kill her, or, you know. And so that's these knowledge deficits are quite profound about ageing, chronicity, multiple morbidity, etc. It's not only within health professions, but also the public that are family carers of these people.
That's absolutely true.
Annie?
Just a couple of very quick comments. So one of the things I think to note, and Pat would know this, there's 902 aged care providers and there's more than 2,500 facilities. An element of that is still very much a cottage industry type, and so there's a lot of skills lacking in terms of how you implement technological advances, etc. So there's a lot of work, I think, to be done before you get a national sort of system happening. The other thing I would just say is that you can get the prescribing right and all those sorts of things. Then there's the actual medication management. So the single biggest clinical concern for our members is actually dementia management, closely followed by medication management. And in a wide number of places, all varied across the country, a whole lot of care workers are giving out medications. They don't know what they are, they don't know what they're for, they don't know what the effects are, and they don't know to look to signs about what to do if there's a reaction to it, and most importantly, when not to give a medication. So we've got a whole lot of other issues around medication management as well.
And thanks, Steve. One of the other things I like about the electronic is that there is only one version, that current version. Recently had someone given something from a paper version that had been replaced 3 months earlier, and there have been 3 or 4 iterations since then, and a medication that had been stopped with good reason had been given 3 months later. So thank you very much. Yes. First speaker on number 1.
Today Andrew Jeremenjenko, earlier today we made an oath that we would not permit consideration of age, disease or disability or any other factor to intervene between my duty and my patient. As an emergency doctor, if I had to choose between a 20-year-old with asthma and a 90-year-old with urosepsis who's demented, I think there are sometimes choices made in a resource-constrained world which disadvantage the elderly, and I suspect that the nursing home issue is a symptom of that as well. Politically, they sort of know they're not going to get as much trouble if the 90-year-old dies than the 20-year-old. How do we actually address that ageism, and should we be actually swearing that oath that we want to give exactly the same care to a 90-year-old as we would to a 20-year-old?
Janet, do you want to answer that first? Ageism?
Fair crack at the whip. That's not a commission issue, that's a societal issue. That is Australians having a conversation about how we value older people.
And I guess that was my first comment about the one thing that I think needs to change. I think there was testimony recently at the Royal Commission that said when an older person goes into residential aged care, they're effectively stateless, and they don't have the same access, to healthcare. And that's one of the things that we are most concerned about, is making sure that the people who come into our care, who are Australian citizens, are able to get the same level of healthcare that anybody else can access. And we have to put aged care in context. We've been talking a little bit about 30 years ago, and I've been around for a long time, and I remember going to visit my grandfather in aged care. Most people drove in, there were car parks. It was a very different population to what we've got today. And I think it's true that one of the things that has happened is that as that complexity has grown, we haven't really changed the funding base in recognition of that. So there's discrimination, and there's discrimination in terms of the way the funding is applied, because it's not really keeping pace. We've had a huge change in the complexity and the complex healthcare that people are coming in with. Funding hasn't kept pace with that. And in addition, those people in residential aged care can't and don't have access to the health that the rest of the population does.
Oh, well, yeah, it was a little difficult to hear your actual question, but I couldn't agree with Pat more. And one of the things I think an important conversation for doctors and nurses to have together is about improving access to healthcare for all people, whatever your age is, and wherever you're living. One of the things that we hear from members a lot is about having to transfer residents into the public hospital system because of the lack of capacity for access to decent healthcare where they're actually living. So that is, I think it is an important thing for us to address.
Look, I agree, and I think that that you've got to make that choice, says that there's something fundamentally wrong. Why is a 90-year-old person with dementia ending up in an ER when that's probably the worst place they should be? There was, it's like the aged care system and the healthcare system are like ships in the night. They pass each other, but they have very little interaction. When really we should have a much more engagement between those two sectors, so that we have outreach out of acute services into the aged care sector, not only to actually address issues that are happening, but also to build capability. And, this again is the siloing of healthcare and aged care. And that's one of the, and you're working in ER, so you're at the front line, you face it. What happens when those silos are not working, the outcome of that siloing of healthcare. So I think that that's one of the challenges for both sectors, but particularly the acute sector, is to look outside their hospital walls and to look at how outreach might work.
Yeah, I think that's really important. I'm hoping that today, we do have conversations from time to time, but I think we actually all need to work together to look at the challenges that we each face. So what the challenges that aged care providers have in delivering the quality of care that the community expects and that we want to be able to deliver, the challenges that the health system has, and how we can actually work together to overcome those. Because absolutely, the prime focus of everybody in this room and the providers that I represent is making sure that the older person has the best possible care that they can.
I might just make a comment and move on, and then we could come back to this, and because I'd like to maybe revisit it if time allows, and that is that there's also in the aged care space the litigious aspect to this. As a GP doing aged care, I know that a number of in fact most of the facilities now have got what seems to be a lawyer-driven imperative that any unwitnessed fall, whether there's any evidence of a head injury or not, that person is supposed to be sent to hospital unless a GP like me can get there within half an hour and say, no, don't send them to hospital. But I'll come back to that in a minute. Chris, I just thought I'd touch on something that was raised in this discussion around the improving access for people in aged care facilities or even older Australians in their own homes. I know that's an interest of yours around sort of telehealth, so perhaps you could comment a bit on that in the context of what we've been saying.
Indeed, thank you. I think many of the important areas have already been touched on, particularly the opportunity using technology to get all the stakeholders in one place, even if it's a virtual place. I mean, often we have relatives, particularly children, who may be interstate, but they've all got a very legitimate and sometimes even a legal role if they're the enduring power of attorney. And also the difficulties, for example, ideally you want everybody who's been involved in the decision-making about a given person in one place at one time. And so you may not have the opportunity to have, say, the geriatrician and the GP and the registered nurse or nurse practitioner all in the room at the same time physically, together with the relatives as needed, as well, of course, as the older person if they're in a position to be engaged in the decision-making, whereas technology allows you to do that. Of course, you've got to make it work well so that it's actually perceived as something that particularly older people are comfortable interacting with. So it's got to work well. The other area, of course, that we haven't touched upon, but I think will be increasingly important is modes of healthcare such as robots. Already there's a lot of work being done on that, and of course you can program a robot to know all your relatives, and also with things like facial recognition, the robot can even read whether your mood and whether you're in pain or not, and all those sort of issues. But clearly it can't substitute for the personal touch, the hands-on reassurance of a highly skilled healthcare practitioner. So it's not a substitute, but artificial intelligence, I think, will be important in terms of improving safety and perhaps alerting people to issues such as inappropriate or perhaps conflicting medication. Also, this issue of virtual attendance. There are many facilities that are just too far off the beaten track to necessarily access all the levels of expertise that might be required. So whether you need a surgical opinion, if the GP wants a surgical opinion, or a second or third opinion, because that's often what the geriatrician is in terms of some of these complex decisions like deprescribing. So I think virtual technology will allow us to access, not perfectly, but will improve the access to appropriate levels of care without all the problems of moving the patient that we've already alluded to. And also, of course, virtual technology to take information such as biometrics, as we know, things like the pulse rate and oxygen saturation and so on can all be delivered to clinicians using virtual technology these days. So I think it's got a very important role. Just today, the New England Journal of Medicine made available their Catalyst document, where they talk about the major innovations that will be occurring in aged care and other forms of care. And right up very high in that document is the role of technology in making this all possible. So I think we have to engage with it, but it has to work. One of the big problems is the failures with technology that have set the agenda back a lot. But I really am very keen that the AMA continue to be a strong protagonist of this.
I might just do something totally unplanned. We've got a wonderful resource person in the room, Steve Hamilton, while we're talking about technology and the use of the My Health record in this space to really enable that transfer of accurate, hopefully up-to-date information between general practice, aged care and the acute sector. And I might invite you to come up to the podium where you can use these and just say something about where that's at. We've just finished the opt-out period, I believe, and what the strategies might be going forward to actually really use the My Health record effectively, particularly in the aged care space where I see a great application for it. So sorry to put you on the spot, Steve, but I know you'll always rise to the occasion.
Thank you very much. Thank you, colleagues. And this is the aged care is one of the test beds that the Digital Health Agency will be looking at to try to, utilise the existing technology that we've got. I raised the issue earlier about electronic prescribing, and we've sort of solved the transcription errors in general practice. Most of us electronically prescribe. And we certainly don't want to condemn our aged care residents to some of the things that we think we've solved in many, many years ago. National residential medication charts that allow people to actually write the orders chart and also prescribe off that's very important. Turning that into an electronic prescription is something that we're working on currently as well. So that's something that's not just in aged care, right across the whole healthcare area. Digitally signing a prescription and transmitting it to a pharmacy so that it can be dispensed anywhere. And that's not very far away, but it does take legislation change in every state in Australia, and there's certainly trials about that happening now, but the Health Department is working on that. Digital Health Agency is working on that. We heard about the Digital Health Cooperative Research Centre. I'm actually on the board of the Digital Health Research Centre, and it's also looking at projects in aged care to see where can we get the benefits. Also, the George Institute held a planning day that was looking at aged care and about what can we do to make residential aged care more homely. And it's very interesting to hear that the lack of access to Wi-Fi for the contractors. Dr. Kidd, who hasn't got access to Wi-Fi. What about the relatives? What about grandma in the nursing home who wants to socially connect with the family? How many of our 70 and 80-year-old people now get the iPad out and FaceTime with their grandchildren? And disconnection from family and environment is actually another big challenge in aged care that we need to solve, not just the medical care. So look, I think there's a great opportunity for digital support. We've heard from about robots and about communication. Look, some of the AI is going to be very, very useful. Not to dictate what we do, but to assist the clinical decision making that medical people do in those locations and assist the nurses. And if we can share accurate, up-to-date information with all the care providers, we can only get better outcomes. Look, I think we are focusing on it with the Digital Health Agency, the Digital Health CRC, but all of us need to do our bit to actually improve it. And we need to walk forward. I hear what you're saying about the challenges with multiple providers. It is a cottage industry. We do need to invest more. We need more educated staff that can actually interpret what's going on. I think I've heard some very strong messages today that we need to build into some of that future. Thanks, Richard.
Thank you, Steve.
I do, if I could, just on technology, want to say there are a lot of wonderful programs and initiatives right around the country that are in aged care homes and that are being used to support people who are living at home that providers are actively engaged with. So there is a lot of good things happening. I think it's important today that we talk honestly about the issues that we're facing and some of the problems that we want to address. But I do think it's also important to acknowledge that there are a lot of good things happening in aged care, including in technology, including a range of initiatives right across the board. We care for over 1 million people a year, whether that's in their own home or in residential aged care. And I think it's important to acknowledge that there's a lot of good work, 350,000 workers, very dedicated workers, doing some very good work. So while it's important that we have these conversations and aged care providers are here to have those conversations about what some of the issues are, we also need to acknowledge that there's an awful lot of good work, including in the technology and in innovation space, while always more can be done.
Annie, just to look at the flip side of that, but I'm happy however you answer it. I'm aware of going to nursing homes that a lot of the nursing staff are stressed by how often the phone rings that is attached to them, and whether they do this wound dressing now or have to go and attend to something else because of a phone call. Is that an issue?
It's an enormous issue, and it's not to discount Pat's point that there are many providers doing good things and trying to do very good things, but there's just so many failings in the system, and we wouldn't be having a Royal Commission if there weren't. So we do have to just, as you say, deal with that and face that. What we've heard, it's interesting, we just submitted to the Royal Commission a 2019 National Aged Care Survey of mostly nurses, mostly members, but also some doctors participated in that survey, and that was a follow-up to the 2016 survey. one of the things we found is that the situation's actually got worse for them in those 3 years. Staffing's got worse, systems have got worse, and with some of the pressures, while it's necessary to have the stories told truthfully, some of the pressures in the media and the pressures of the Royal Commission has seen some providers putting in policies that have just made their jobs even more difficult. So one of the things is, and this is for nurses and care workers, so there's been institutes of protocols because they're worried of whoever mentioned the litigious environment. They're worried, providers are increasingly worried because of this intense scrutiny, and so they might be in the middle of doing something with a resident, but because there's a protocol around call bells, they might have a resident in the shower. They have to turn it off and go and answer the call bell, leave that person there, and then come back and attend. That's just a tiny little example of the sorts of things that then a bit of a knee-jerk response to some of this scrutiny is causing. We had a GP tell us that he was trying to, you know, put in some orders or instructions around one of his residents and sat for 15 minutes on a phone while someone tried to find the registered nurse so he could give the instructions. So there's a need for us to fix a lot of things. It does come back to the staffing issue. And while I've just got the floor for just a second, I would like to say I couldn't agree with you more about the need for proper education and understanding the particular conditions of the frail-aged, dementia of course, but it will never negate the need for the right numbers of staff with the right skill mixes. You could have one of the most highly qualified, wonderful, best attitude in the world. If they're 1 to 150, it's just not possible. So we need to do the things in concert. And just a final little comment on the My Health record. So the Federation thinks that this has so many opportunities, the My Health record. It can deliver us so much in terms of, you know, we don't have, and I'm just shifting out of aged care for a second, we don't have very good primary health data sets in this country. We don't have very good national health data sets. There's so much that we could use to underpin evidence-based improvements and practice. Notwithstanding, in aged care, we are going to need to bring the whole sector up to be able to manage the My Health record, but it can only bring improvements. And one of the things we hear from, particularly from our members, is that the documentation, while the requirements are sort of extraordinary, they're not necessarily telling people the right things. I had a nurse practitioner tell me the other day, working with a geriatrician in Canberra, and she'd been asked by them to go and visit a particular person, do some assessment and plan some care. And she struggled to find out what exactly was at the basis of this man's particular issues and problems. And through all the documentation, she couldn't find out. She eventually found out, not through anything that was recorded in the aged care facility, that the man had motor neuron disease. And nobody had that anywhere in the care plan. So anything that starts to help those sorts of problems is just going to be really welcome. And I think the My Health record has great potential.
Yep. Now, before I take the next question, I'm sorry, I'd just like to kind of, I see that as a bit of a segue for Janet around how do you see the Commission being supportive and yet at the same time fulfilling its regulatory functions in this space where we're hearing about how a number of things have got a bit worse over recent times. So I suppose, what are the regulatory tools that the Commission has to penalise aged care providers who don't meet standards? Has there been an increase in non-compliance over time? Is this because the aged care quality is decreasing or has regulation increased? Can you describe the standards that relate to clinical care? So it's a bit of a big question, but it's one I've been itching to ask and it just seemed like a nice segue, I'm sorry.
All right. I'm going to reframe your starting question. When the question was, what regulatory tools does the Commission have to penalise aged care providers? We don't come at our job that way. I much prefer to talk about the regulatory tools we have, which assist providers to maintain compliance with the standards. Now, there are penalties associated with persistent non-compliance, which results in risk of harm to aged care recipients. But if you can imagine a pyramid, we are a risk-based regulator and we are responsive to what we find in a particular service. At the base of the pyramid, we use our functions for consumer engagement, and these are in the Act, the Aged Care Quality and Safety Act. We use our functions for consumer engagement and for education to work actively with the sector to ensure that they are knowledgeable about and accessing best practice, guidance and advice in delivering aged care, including clinical care, to their consumers. And we also have powers for accreditation and for compliance monitoring. So we have legislated standards, quality standards, current accreditation standards, soon to be shifted to a new platform from the 1st of July. And I have audit teams who go to services and review those services, assess them against the standards. And many of them, the vast majority, are fully compliant. So while it is always easy and indeed necessary to draw out examples where a service has done the wrong thing and become non-compliant, and my agency deals with many of them, I did want to make the point that the majority of providers are found to be compliant with the standards. Where we find non-compliance, we have additional tools available to us. We talk about a timetable for improvement, which is effectively imposing on the service a requirement to make good the deficits that we've identified against the standards and give them a time frame in which to do that. And we keep eyes on, we keep monitoring them as they progress their continuous improvement and recovery plans, if you like. Now, if we find risk of harm, and this is really important, if we find risk of harm, then in association with an area of non-compliance against the standards, then that is reported directly to the Commonwealth Department of Health. They sit in judgment on that finding. Typically, they will find, forgive me because it's technical, but they will find severe and immediate risk, which then leads to the imposition of a sanction. That's getting very serious. A service under sanction typically is unable to accept any new placements into that service. They must recruit and appoint an administrator and a nurse advisor, and they have a very onerous expectation placed upon them about addressing those areas of non-compliance. It may be that my commission also makes a decision to vary their period of accreditation. So maybe they get 3 years initially. If they are found to be persistently non-compliant and there are findings of serious risk, it's entirely possible that I will reduce their period of accreditation and ask them to go through a re-accreditation audit in order to re-establish their platform for full compliance. At the very apex of the triangle, and it's not a function I have within my Act, it's a function which is deployed by the Commonwealth Department of Health. The Commonwealth Department can revoke approved provider status, which effectively means that the provider is not able to attract Commonwealth subsidy for the delivery of aged care and effectively cannot run their business because they lose that very substantial revenue stream. So it's a progressive, risk-based approach to regulation, and it is entirely geared to what we find when we go and visit the provider and we make an assessment against their performance, against the standards. You asked, Richard, about levels of non-compliance, and it's true, and the data bears this out, that there have been increased findings of non-compliance over time. Now, partly that is artefactual. Partly that is because as my agency and my predecessor agency, the Australian Aged Care Quality Agency, as we moved more into this risk-based approach, we are looking more closely at levels and areas of risk, sector-wide and by specific provider. And we are ensuring a greater intensity of the regulatory gaze is placed upon those service providers of higher risk. So it then follows logically, if we are looking at higher risk providers, there's a greater likelihood we will find that there are areas of non-compliance. Additionally, from last year, we introduced unannounced re-accreditation audits. And when the provider has no knowledge of when we are going to present, we have found, less well placed, less reliably placed to demonstrate compliance, and again, perhaps unsurprisingly, and that too has contributed to increased findings of non-compliance. The unannounced visits are generally regarded by the sector as reasonable and fair, and I need to say that, so that this is not regarded as an unfair imposition. by service providers. They understand, as indeed the regulator fully appreciates, that a service needs to be compliant with the standards 24/7.
I might just bring it back for the members here. So, as well as accreditation, I'm assuming that the Commission would be very happy to hear from doctors who go to aged care facilities. For example, to follow up on Andrew's area of interest, dementia, going to a place where there's terrific pressure on the doctor to prescribe antipsychotics, maybe benzos, and the doctor can see that there could be a lot more done in terms of behavioural management, distraction, a number of other interventions and techniques that are non-pharmacologic. Would that be an area that the Commission would be interested in? And if so, how would doctors such as the ones in this room inform the Commission of their concerns? And then, as a segue, I would be interested if we can get some comment from Andrew about how much it would cost to upskill personal carers and nurses in dementia management. But take it away.
Absolutely. There are a number of avenues for that information to be made available to the Commission, and we would welcome hearing about any circumstance where that was the perception of what was occurring, or that was the lived experience of a practitioner, for example. We have a complaints function, so it could come in as a formal complaint, which we would investigate and work with the provider to obtain the details of that, and then satisfy ourselves either that was a misapprehension of what was occurring, or more possibly that indeed there was an irregular practice there that needed to be put right. We also have the opportunity for individuals who are associated with a care facility to give us intel about that facility in advance of one of our accreditation visits. And these are known about in advance. The date of the visit is not known, but the period in which the visit may occur is known, and we require providers to ensure that the residents of the facility, for example, their family members, and others who may be associated with the facility are aware that we are coming in coming months, and the provider is required to ensure that those individuals have access to our 1800 number and can give us information about their perceptions of care in that facility.
Yes.
A general practitioner would be one of those people in scope who could readily pick up the phone, ring our 1800 number, and provide us with that information about a particular service.
Could I just add one thing there? It's important to know that those things are possible, and if people feel a need to take them up, obviously they should. But could I also encourage, I think that what we do have to do is work together more, and if you do have concerns, actually also talking to the aged care provider
Yes.
about what's happening on the ground and how you might be able to work together better, what the issue is. Aged care providers exist because they want to provide good care for older Australians. So I'd really encourage you, as well as knowing that you've got those avenues, and if you think that's appropriate, that's what you should do. But I would also encourage you to actually engage. I think that's one of the things that I would hope most out of the conversations that we're having now, out of the Royal Commission, that we start to look at how we work together to address some of these issues, because we actually all want the same thing.
So just before we take the next question from the floor, Andrew, any comment on what it would cost to upskill the personal carers or nurses? What sorts of courses are available online, or however they might do it?
Look, it's what it would cost to upskill nurses, etc. Is not an area that I've actually done work in. Annie may well have done some work in that area. I mean, what we do have though is a free online course called the Understanding Dementia MOOC, which is a massive open online course that comes out of the University of Tasmania, out of the Wicking Centre, that is rated out of the 8,000 or odd MOOCs in the world, the #1 health and medical MOOC in the world. And that has one of the highest completion rates of any MOOC in the world. And that we know now, we've had published in a journal, which is, and one of the nature journals, that irrespective of who you are or how old you are or what your background is, doing that course will result in a statistically significant improvement in your knowledge of dementia. and that the less knowledge you have when you start the course, the greater the improvement will be. So that at the end of the course, you've got much closer, you know, those that come in with a higher score and those that come in with a lower score, those scores are much closer. So that's with respect to dementia. I think that, and that's a free course that's online, and it's run twice a year. So I think that's the sort of course, from my perspective, is something that is not going to solve the problem, but it's, my colleague Anna Howe always talked about raising the floor. So that's going to raise the floor of where people's knowledge is at. And what we've found is that what that means is they can have, this is nurses, care workers, family members, whoever it might be, they can actually engage in informed discussions about dementia rather than pooling ignorance and finding themselves in conflicting situations. And I think that's part of the issue about how we work together, is that we've got to have some sort of common knowledge base. So I've also, you know, in terms of that MOOC, I've got colleagues, GPs, that have talked about it actually transforming their practice as general practitioners with respect to people with dementia, which just, if I can take a minute, brings me to another bit of work we're doing, which is looking at providing workshops to GPs around dementia as a part of Dementia Training Australia. And we do that through the RTOs, and we've been doing that for a long time, and we have a very significant database. What is interesting out of that is that general practitioners, by and large, don't have a good knowledge of dementia. And you'd have to wonder, why would they, when the probability is they probably got very little training about dementia in their undergraduate degree, and they may well have gone through general practice training with almost no dementia content. What's a little bit scary is that the registrars have the supervisors, so these are the senior leaders in the practice who supervise registrars, their knowledge of dementia is basically no better than the registrars. So this is a really significant issue. Now, we've just had that published in one of the BMJ journals, and I'm very happy to send that paper to anyone that's interested in that. What we do know, though, is if they do the workshop, they have a really statistically significant increase in their knowledge of dementia. And we also know, in a paper that's just about to be submitted, that their confidence absolutely increases, so that, and that's correlated to their engagement. So their actual capacity to engage with families and people with dementia improves because their confidence is increased. So in general practice, you know, we do, these are significant issues in terms of how we actually provide, the discipline provides care and support into that sector.
My turn? Conrad Weiner, I'm in rehabilitation medicine. Firstly, to congratulate the panel on the work that they're doing to improve management of aged care. But as far as the government and AMA approach is concerned, I feel that there hasn't been enough emphasis on educating the public in lifestyle. The assumption which seems to be being made is that increasing age and the increasing instance of aging in the population inevitably involves equally increased chronic disease. I feel that that is not correct. I feel that the government and perhaps the AMA should be spending equal time, not instead of the work that we're talking about today, but also equal time in teaching the public on lifestyle medicine. I think that the population would look particularly to general practitioners to be giving that education, and in turn that means that medical students should be having more emphasis on lifestyle medicine. Could I just very quickly give my personal bit? Twice you've referred to today to 90-year-olds and how we should manage them. I'm only 2 years off that. I began my first City to Surf run, 14-kilometre run in Sydney, when I was 46. Last year, after 41 years of running the 14 kilometres every year with 70,000 other runners, I didn't do it for the first time. I did the half marathon instead. and to my amazement, I came back with a gold medal. But the point is that the discussion we're having today is essential, and congratulations on the work that is being done. I'd like to suggest particularly that the AMA in the future also pays equal attention to teaching the public, perhaps through general practice in particular, on lifestyle, healthy lifestyle. I don't take any vitamins, I don't take any supplements, I lead a healthy lifestyle. Thank you.
Thank you. And I'll take that as a comment, and it does remind me that that was why we had the AMA Healthy Ageing Committee.
Can I just add one comment to that, which is it's a really, really good point, and not everybody goes into aged care, and what we're seeing is people go into residential aged care in particular much later and with more complex healthcare conditions. But there's also a lot of good work being done around wellness and reablement for older people. It's not always a one-way trajectory for people, and there's been some fabulous programs, one in Western Australia where services went in for 12 weeks, they worked on goals with people, and often at the end of that 12 weeks people didn't need any service at all for up to 2 or 3 years, or they needed a lower level of service than what they were originally assessed as needing. So it's a really good point and something that we should always focus on.
Can I just...
Simon? Sorry, Andrew.
I think that's absolutely true. I mean, at the Wicking Centre, we also have a second massive open online course called Preventing Dementia, which is exactly what you're talking about, because we believe a third of dementias are preventable. So that's another one that you can give your patients, who you can refer your patients to. Again, it's free, online, and I think actually you can enrol in it right now. So just look up Google Preventing Dementia and take it from there.
Thank you. Do you want to make a comment?
I was just going to say, we couldn't agree with you more. My mum's 83 and she's a nurse and she's still working, believe it or not, on a maternal and child helpline. So I also just think that we need to start that kind of investment, earlier and put a lot more resource into it. She didn't run any marathons though. Not even half.
There's still time.
There's still time.
Thank you. Simon.
I'm Simon Torvaldson. I'm a GP from WA, and you'll be pleased to know that I do tell my patients that I'm a wellness doctor, not just an illness doctor, and we do talk to them about lifestyle and the benefits it will bring them now and well into their future and old age. But my question really is about the how rather than the what. We've been talking about the what, and I think that actually most of us know what we need to do. I would argue that we don't need a Royal Commission to tell us what to do. We already know it, we've been talking about it. I, along with a lot of other people, could write down the blueprint for the future, given a free hour now, and I'm sure a lot of you could too. So my question really is more around how are we going to progress this? What strategies do we have in place to actually change the system? We agree it needs to be changed. We know a lot of the changes need to be put in place, and some of them are reasonably cost neutral and probably will save money. But what strategy do we have to move this forward? And looking at the Royal Commission, what strategies do we have to ensure that the outcome of the Royal Commission is not just more regulation, red tape, compliance, the evidence that I gave to Parliament just recently, I said to them that the vast bulk of carers, and in fact all the carers that I made, all the staff I made in nursing homes and aged care facilities, they all want to give good care. It's not about bringing a whole bunch of bad people into line. They all want to give good care. So how are we going to develop a strategy to change the system that allows and facilitates and encourages the provision of good care rather than just binding up everyone in red tape, because every minute spent on compliance is actually a minute you can't spend actually looking after the people that you're supposed to be looking after.
May I, Pat?
And I'm just thinking we've got 9 minutes and 10 people have got questions, so we might try to be very, very quick with our answers, and if people can focus their questions.
I'm presuming that Pat won't disagree with me on this answer. We have a strategy. We went through the process of developing the aged care workforce strategy from the task force that was set up. The sector is in reasonable agreement that because that's what we need. We have a strategy there, certainly to cover the workforce issues, and it's the first time that someone actually stepped back, because what we've tended to do is get down this rabbit hole of, not that they're not important, they're so important, palliative care or dementia or this rabbit hole over here. The strategy, the task force stepped back, looked at the entire sector, has 14 recommendations of how we can proceed. It's sat on a shelf since June last year. So the other how is we need the political commitment to make it happen. So it's been the Royal Commission is a useful exercise. It's allowing people to be heard in a way they've not been heard before. And we hope that we get good recommendations that are not inconsistent with the strategy that we already have, because many of you probably know we have a shelf this wide of reports and inquiries. You suggested it into aged care. We know what to do. I think it comes down to some political will and joint sector involvement.
It absolutely does. I do agree with that. But I do think aged care providers have embraced the Royal Commission, because there's no doubt that we're actually having a community conversation now that we haven't had. We've tended to have, there'll be a story that comes out and providers will stand up and take responsibility for that and look at continuous improvement. But this is an ongoing community conversation talking about all of the issues that confront, and the issue of discrimination is in the Royal Commission. The need for us all to actually work together to support older Australians is in there. So I think the Royal Commission, and Annie's right, there are many, many reports. And the Royal Commission shouldn't be used as an excuse to stop us from doing things that need to be done. Some of it does go back to absolute commitment around the workforce strategy, but also it's important for you to know that in residential care at the moment, there are 63.5% of all facilities in rural and remote areas that are now operating in deficit. And in metropolitan areas, it's over 40% of facilities that are operating in deficit. So there is a real need to actually acknowledge that the client base that we're supporting has got higher needs, and the funding hasn't kept pace with the needs that people have. So that's another thing that we really need to focus on as well.
Thank you. Annette?
Annette Newson, Rural General Practitioner, inland rural, one of the country towns that they've really pushed aged care. So we have 100 aged care residents and 3 aged care villages, a severe workforce problem in nursing and doctors. And we're visiting specialists, and not many of those, and to get access to resources, especially in the aggressive dementia patient, is a nightmare for us. Technology, we should be able to get assistance, but we cannot get a telehealth assistance ever for advice. And we are being told to transfer the patients via their Royal Flying Doctor Service under an involuntary admission to the metropolitan centres. Which is extremely difficult, and we've just said one of the barrister's sons has just told us that we will not be doing that because it's illegal. We really need more help. Please don't forget rural.
Okay. Is that a comment?
I think it's a comment, and I think it backs up what we've been saying today, that making sure that people have equal access to healthcare, and that we're working together to do that is incredibly important.
And we would suggest that particular attention needs to be paid to ensuring that rural and remote, those areas, can have proper access. They need to have special funding initiatives. So much seems to get contained and absorbed by the large inner metropolitan providers, and it seems to disadvantage, while advantages them, disadvantages many parts of the sector, probably many of Pat's members actually. And there need to be good incentives to get the workforce out there as well. So we totally support that government to get behind that and put in some proper funding that can't be attacked by anybody else and is actually given to rural and remote areas. One thing the Federation would always like to be extremely clear about, while we're saying in the terms of the staffing model we're talking about and how it's going to need an implementation plan, it's going to take time, special considerations are going to need to be given to rural and remote areas, but one of them should never be that they should accept less. We already know that outcomes in rural area, health outcomes in rural areas are worse just because you don't live in a city. Why should that be? We should not accept less in aged care either. So it needs additional input.
And before we leave this one, Janet, do you see the Commission having a role in putting forward some of these infrastructural problems, particularly in the rural settings, and perhaps enabling the political process to better support those areas?
I'm not sure that's a question for an independent statutory officer. But let me agree with what Annie was saying in terms of the rural and remote residents not accepting less. The Commission has a singular gaze on managing complaints, educating, engaging with consumers, and accrediting, assessing and ensuring and monitoring compliance with the standards. And we apply it without fear or favour, and we look to the particular challenges which are found in rural remote services, and we work a little harder to ensure that they have access to the necessary guidance, that they are supported in undertaking the necessary learning. I'm not discounting the influences of funding models and workforce supply issues, which are always more problematic, more challenging the further away you get from urban centres. But certainly the Commission is leaning into ensuring that we are positively discriminating in favour of the support we provide to our rural remote providers to ensure that they have the same sort of access, equal opportunity access to the resources that they need. If I may just add on a more provocative note, and I'm conscious that this may not sit well with everyone, but I need to ask you to self-reflect. To what extent do you individually own some of these problems? Because we talk about clinical care in aged care services or for aged care consumers, and that's largely about doctors. It's also importantly about nurses and allied health professionals, but it is about doctors. So to what extent do you as individual practitioners recognise a role for yourselves, and particularly if you're general practitioners? Now, we can talk about incentives and financial arrangements and so on, but I think it's a fair question that I would ask of you, and I'd be pleased if you'd reflect on that.
Just to answer that, in our area, the large aged care presence we've got is a negative workforce issue.
Thank you. Look, I'm sorry, there's only 1 minute and 40 seconds to go, so I think there'll be one more question, but there's been so much interest, it's really great to see. Perhaps people who don't get the chance to ask the question here can send emails to Hannah and Wigley and Luke Toy, and we'll do our best to follow some of it up offline. But I think we've got time barely for one more question. So it'd be you, yes.
Terry Ahern of Melbourne GP. Just 3 quick points. Firstly, prevention. Patients in their homes need support to look after by the carer. So there needs to be easy access to respite in the home and for aged care homes so the carer doesn't get burnt out. There needs to be more funding for GPs and nurses to do visits, and that funding for GPs hasn't gone up in the last 25 years. Secondly, after hours is disaster. I mean, we're not funded to look after our patients after hours, and the locum services are called in. So if there was funding for a phone communication to the facilities, it would be significant. And having things like impress boxes at the facilities where they can give readily medication without sending patients to hospital would save a lot of money. And thirdly, just a lot of GPs may be up for legal problems if they looked into about giving these antipsychotic drugs without discussion with families. And it's been going on, but that's because we're often pressured by nurses because the poor staff nurse ratio numbers. So we need more, GPs need funding to have discussion with the family. It doesn't, as psychiatrists are, they're funded for it. GPs don't get funded for having the discussion with the families.
It's really important so we care for over 1 million people, around 800,000 of those are people living in their own home. And we do have the problem at the moment where home care packages which are provided to support people and to support carers, there are 128,000 people now waiting for home care packages. So there's a real problem in terms of the supply and demand. There is some legislation currently being enacted that is around restraints, and one of the things that I think is unclear is about consent, and I think that that's something that AXA and the AMA should be talking about to make sure that that's clear and supported and happens in the way that we would all want to see it happen.
Well, thank you very much. Would you like to say something?
I was just going to say we would agree to, we've talked a lot about incentives, but GPs need incentives to leave a practice, don't they? And go and visit the residential facility, and there's a lot of problems that we hear about that a resident or a person has had a GP for a long time, but they move into a facility that's now near their daughter or wherever, and they've lost that connection. So a lot of those, there's multiple problems related to that, but we would certainly agree that incentives could definitely be improved. And it only makes it better for nurses if they have better access to GPs and doctors and geriatricians as well. Just, there is the issue that Pat just talked about the legislation coming in about mandatory restraint, and
no, not mandatory restraint.
No.
Quite the contrary.
Sorry about that. Thank you. See, that's why she's the Commissioner for Quality and Safety. A good pickup. Against, not mandatory restraint, chemical and other restraint. Just one of the problems we have again, and somebody asking a question earlier talked about all the sorts of regulation not sort of maybe directed in the right way. We've had a good period of time to look at the restraint issue, and the responses come very quickly rather than 2016 when it was first raised. But one of the issues is you've got to consider the consequences. If you put in rules around how you can't do these things, and I'm not suggesting that restraint is a good option in any circumstances, but like I was talking before about what sorts of protocols people put in about answering call bells and stuff, if you put in different things and you haven't got the structures or the staff or the other supports there to do it, you've got to look at what the unintended consequences of some of these issues could be and how to introduce them appropriately. But completely agree with you, especially around consent and family involvement.
Thank you. So in closing, I'd just like to say, although we've speaking mainly about the doctors and the nurses and the providers and the regulators and the researchers, it's all about our patients. It's all about their residents, their clients. It's all about making things much, much better for them in the future. We've slipped a bit, but this is now time to really start improving things again and getting back to giving our older people care with excellence. So if we can thank our panellists and panellists online, thank you very much. And I'll just give you your things. There we go. So thank you very much, Matt.
Okay.
Sorry? Yeah, that's fine. Thank you. Lovely, thank you. Lovely, thank you.
Thank you. Okay, bye.
But we're going to try and catch up some time now. Thank you. One of the problems of having some really complex discussions is that the panel sessions do potentially give off a lot of information and a lot of engagement, and unfortunately we are running a few minutes behind, but we're going to try and see what we can do. Anyway, it is indeed an honour to introduce our next speaker, the President of the World Medical Association. Professor Leonid Edelman is a distinguished anaesthesiologist and an intensive care physician. He's a clinical associate professor at Tel Aviv University and has completed 2 terms as President of the Israeli Medical Association. He began serving as President of the World Medical Association in October 2018, and it is my pleasure to invite Professor Edelman to address this conference. Please warmly welcome him.
Thank you for a kind introduction. Dr. Tony Bertoni, President of the Australian Medical Association, dear colleagues and friends, thank you for the gracious hospitality. I'm honored to be here at the AMA National Conference in Brisbane. I'm sure the meeting will be a resounding success. The Australian Medical Association fosters and upholds the WMA's tenets daily. In that spirit, you fulfill the WMA mission by serving humanity, by endeavoring to achieve the highest standards in medical education, medical science, medical art, medical ethics, and healthcare for all Australians. Your stalwart commitment is admirable. I would like to use this opportunity to stress the importance of participation of the Australian Medical Association in the World Medical Association. Tony is a member of the WMA Council and contributes a lot to its activity every time that we meet. This year, We have had the 212th WMA Council meeting that was held in Santiago, Chile, and was attended by delegates from all over the world. A wide range of challenges faced by physicians universally are on the table of World Medical Association. Some of them, like universal health coverage based on good primary health care, can be definitely influenced by AMA, as well as antimicrobial resistance, non-communicable diseases, minor asylum seekers, and so on and so forth. In Santiago, it was determined that policy work should continue on critical issues such as physician-assisted suicide and dying, augmented intelligence, violence against healthcare professionals, physicians' burnout, and the patient-physician relationship. Recently, WMA has had a meeting in Tel Aviv on the future of physicians, Physician 2030. The issue of physicians' health you have discussed during this conference is one of the major challenges physicians all over the world will face during the next decade. I hope to welcome many of you to the WMA's General Assembly scheduled to take place in Tbilisi, Georgia in October. I hope some of them will be able to visit our next meeting in Tokyo about universal health coverage. I'm sure your input and presence will provide tremendous added value. Once again, it is great to be here in Brisbane, the state of Queensland's capital. I look forward to speaking with you and learning more about the physicians in Australia and the Australian medical system. Thank you very much indeed.
Just again, a little gift there. Thanks a lot. Thank you. And thank you. All right then. Now, thank you, Professor Leonard. Now we have got another award now to present, and this is the AMA Excellence in Healthcare Award. The AMA Excellence in Healthcare Award is for an individual, not necessarily a doctor or an AMA member, who has made a significant contribution to improving the health or healthcare in Australia. The person may be involved in health awareness, health policy, or health delivery. This year's award goes to a true champion of public health, a fierce advocate for immunisation and for vaccine safety. Dr. Alan Leib, a GP from Perth, who has demonstrated his ongoing commitment to quality medical care for more than 3 decades. Perhaps his most important achievement is developing the SmartVax tool, now used nationally to deliver near real-time active adverse event information to general practices and hospital immunisation clinics, and to prospectively monitor the safety of all vaccines given in Australia. Dr. Leib was motivated by the events of April 2010, when the use of the seasonal trivalent influenza vaccine in children was abruptly suspended following unanticipated spike in febrile convulsions and other adverse events after the use of Fluvax. The suspension decreased public confidence in vaccinations and more pointedly caused a loss of confidence by some doctors in childhood influenza vaccination. Subsequently, there was a quick fall in the proportion of children fully vaccinated for influenza from 45% in 2009 to just 7% in 2011. High immunisation rates are critical to protecting the nation's health, and as we have seen overseas, any decrease in immunisation rates can lead to an increase in the incidence of vaccine-preventable diseases, such as measles. Vaccinations and immunisation are key policy and medical issues, particularly at a time when highly dangerous anti-vaxxers are spreading false and potentially lethal misinformation. Dr. Leib was determined to never see another situation where the systems in place were unable to protect potential vaccine safety threats in a timely manner. He partnered with a software developer to create SmartVax, a tool, as I said, to actively monitor adverse events following immunisation. SmartVax uses SMS and smartphone technology and is a world leader in delivering active adverse event surveillance. The program has actively monitored almost 2 million vaccine antigens, over 1.3 million immunisation encounters, and is in use at almost 300 practices and clinics across Australia. Importantly, in an age where false and dangerous disinformation is being spread by unqualified individuals, the work of Dr. Leib and his partners has helped provide the evidence-based reassurance to the public and health professionals about the safety of vaccinations and the National Immunisation Program. Dr. Alan Leib is certainly a worthy recipient of the 2019 AMA Excellence in Healthcare Award. Please welcome him to the stage.
As doctors and healthcare professionals, we have a duty of care to our patients to firstly do no harm. Allow me to share my story with you. I was devastated in 2010 when the childhood influenza immunisation program was abruptly halted due to an unprecedented increase in adverse events. We were surprised to find in our medical centre that of 337 children immunised, more than 100 children had suffered a reaction. This included 8 hospital attendances and 3 children with seizures. Almost all reactions were due to CSL brand FluVax. We were immunising our kids during the day, and they were presenting to the emergency department at night with pyrexia and seizures. We had absolutely no idea that this was occurring. I was determined that this would not happen again, and devised a very simple process for sending SMS messages to parents of children immunised, inquiring if they'd had any reactions. Feedback was great, parents were thrilled that we actually cared, and our nurses and GPs considered this their prime duty of care. I teamed up with Ian Peters, a software developer, and together we developed SmartVax, an automated system utilising SMS and smartphone technology for the active surveillance of adverse events following immunisation. We consulted with the WA Health Department, further developing and expanding SmartVax to like-minded GP practices. Today, the SmartVax network hosts almost 300 sites, predominantly general practices, Aboriginal medical services, as well as local government and major hospital immunisation clinics. To date, we have monitored over 1.5 million immunisation encounters across 42 vaccine antigens, and we report a patient response rate of well over 75%. Partnering with Ausvac Safety, our data has actively monitored the safety of flu vaccine across all ages since 2014. The safe introduction of new vaccines to the National Immunisation Program, and also the safety of recent changes to the immunisation schedule. We have contributed widely to local and international vaccine safety data, and thankfully to date, we have not detected any safety signals. Thus far, we have monitored over 100,000 immunisation encounters for influenza this year, and we can confidently report that the 2019 influenza vaccine is safe across all ages. I believe the true utility in our network is as a springboard to further enhance patient care and as a tool for ongoing practical primary research. We have recently teamed up with the National Allergy Strategy and developed Smart Start Allergy, a new tool utilizing the same technology and network. We have been able to demonstrate that a significant proportion of infants are now consuming peanut in the first year of life, and we hope to further understand food allergy in infancy and also contribute to individual patient care. I humbly accept this reward, not only on behalf of my SmartVax team and immunisation providers, but the Australian public, our patients, who truly deserve to be confident of the safety of our national immunisation program. Thank you.
And now we turn to the usual AMA Roll of Fellows announcements. Delegates, special guests, ladies and gentlemen, we now welcome to a special and immensely pleasurable part of the proceedings. We get the chance to formally recognise the outstanding contribution made by a select number of our colleagues. The AMA is one of the nation's most respected and influential voices in medicine and health policy, and this is due in no small part to the integrity, the knowledge and judgment that leading AMA members have displayed when contributing to health policy discussions and debates. Whether it be vaccination, hospital waiting lists, Indigenous health, aged care, obesity, e-health, e-cigarettes, medicinal cannabis, or Medicare freezes, the AMA is turned to as the voice of reason. The 7 people being admitted to the Roll of Fellows today exemplify all that makes the AMA such a trusted and well-regarded contributor to the national health policy and debates. It is wonderful to have the opportunity today to show our appreciation for the outstanding contribution that each has made. It gives me great pleasure to announce in alphabetical order the 2019 admissions to the AMA Roll of Fellows are immunologist and past AMA New South Wales President, Professor Brad Frankham, OAM, distinguished neuroradiologist and past Royal Australian and New Zealand College of Radiologists President, Professor Mark Kanguri, AM, orthopaedic surgeon and AMA WA President, Dr. Omar Khorshid, anaesthetist and past AMA SA President, Dr. Andrew Lavender, past AMA ACT President and Dermatologist Associate Professor Andrew Miller AM, Consultant Surgeon and Ex-Army Officer Associate Professor Susan Newhouse, and past AMA New South Wales President and Dermatologist Associate Professor Dr. Saxon Smith. They have been added to the Roll of Fellows in recognition of the outstanding contribution each has made to both the AMA and the medical profession, and I'll call them up to the stage in that order. Professor Brad Frankham is a prominent consultant physician specialising in immunology and allergy. He divides his time between Campbelltown and Camden hospitals and his private specialist practice, and an immunology and allergy clinic at the Thorowal Aboriginal Medical Service in Campbelltown. He has held academic posts with the Universities of Sydney and Western Sydney and has been involved in teaching and training of thousands of medical students and young doctors. He served as President of AMA New South Wales from 2016 to 2018 and Vice President for 2 years previous to that. In addition, he served on the AMA Federal Council for 2 years. Brad was a central figure during the Campbelltown and Camden Hospital crisis, when the hospital was accused of poor standards of care and a litany of other failings in the early 2000s. The state government and the media were only too keen to scapegoat the doctors in order to deflect from the chronic neglect the whole of the southwest of Sydney had suffered from successive governments and the bureaucracy. People's careers were in tatters and doctors demanding due and fair process were subject to serious intimidation. With the support of AMA, Brad was able to lead clinicians to stand up to what amounted to the tyranny of the government at the time. Out of that mess, and against the odds, South West Sydney now has the biggest hospital in New South Wales at Liverpool. Campbelltown, Camden, is now the second busiest emergency department in New South Wales and a very successful medical school in its 12th year, producing very fine medical graduates. Brad has dedicated much time and effort to raising the profile of AMA and has had a profound influence on Campbelltown and Camden hospitals and medical teaching over several decades. His contributions to the profession and to the welfare of his patients and colleagues are exemplary. Congratulations, Brad. Professor Mark Kanguri AM has served the AMA, medicine and public health for more than 4 decades in a range of leadership positions. He has done this while making significant contributions to medical education, government policy and other professional bodies, and developing an international reputation as a neuroradiologist. Mark graduated from the Newcastle upon Tyne University Medical School in the UK in 1971 and undertook training as a junior doctor at the Royal Victoria Infirmary and the Teaching Hospital of Newcastle University. He joined the British Medical Association in 1970 and after moving to Western Australia in 1976, continued his membership as a member of AMA-WA. For more than 40 years, he has been an active and valued member who has contributed to medicine, public health, research and the AMA in a wide range of roles. In 2017, Mark was recognised with the Order of Australia for his contribution to medicine in the field of neuroradiology, to education and to medical associations. Mark's leadership was best demonstrated in 2006 when he demonstrated his willingness to make a stand and resigned as a head of Royal Perth's Hospital Radiology Department over poor clinical leadership. The AMA is proud and privileged to have Mark as a long-standing member who has made an exceptional contribution to medicine and the AMA, both in WA and on the federal stage. Congratulations, Mark. Dr. Omar Khorshid is the current president of AMA-WA and is one of the youngest presidents in the association's history. For almost 2 decades, Omar has been a prominent AMA voice both within Western Australia and nationally. As state president, Omar has focused on strong advocacy for better clinician engagement in public hospitals. He has also forcefully advocated on a range of key public health issues, including obesity, vaccination, and alcohol and drug abuse. In particular, Omar has played a major role in driving the public debate over end-of-life care and the proposed legislation relating to euthanasia and palliative care, determined to ensure that AMA's views were strongly known. Demonstrating tireless energy, Omar drove the AMA-WA Symposium on End-of-Life Care, one of the most successful and pivotal events held by the AMA-WA in recent years. He has made appearing before the parliamentary committees and inquiries a key part of AMA's contribution to the public debate. On a national basis, Omar has had impacts in areas such as medical training, corporate governance, constitutional change, and specialist representation. He has consistently taken a robust stand on behalf of the medical profession and the public health as a whole. He has strongly argued that the health in Australia is something worth paying for to reflect our standing as a first world economy and a caring community. The AMA is privileged to have Dr. Omar Khorshid as a long-standing member who has made an exceptional contribution to medicine both in WA and on the national stage. Congratulations, Omar. Dr. Andrew Lavender has given outstanding service to the AMA over many years. As an AMA SA Council salaried medical officers representative, as Treasurer, Vice President and then President in 2009 and 2010, and as a Federal Councillor. With a particular interest in the role of public hospitals and primary care, he is a strong advocate for the public sector doctors and the patients they care for. Andrew was AMA SA President at a particularly challenging time, which included debate over the establishment of the Royal Adelaide Hospital at a time when the views of the profession, community and political arena were divided. Andrew has made an extraordinary commitment of time, energy and attention to many and significant issues for the AMA and its members, in addition to his busy clinical life and responsibilities as a public hospital anaesthetist. His advocacy work on behalf of the profession included undertaking significant media engagements during which he advanced the AMA state and federal advocacy and policies. He has given many hours of his time as well as his energy, insight and capacity to break down problems into workable solutions. He has done so with humour, modesty, perception and goodwill. He has been a great colleague and the AMA and the profession have a lot to thank him for. Congratulations, Andrew.
Go on, let it out. There you go. Thank you.
Associate Professor Andrew Miller, or as we know him, Andrew Miller East, has served his colleagues through his leadership and involvement with the AMA, the AMA-ACT and the Australasian College of Dermatologists. Andrew first joined the AMA as an intern in 1981 and has served and continues to serve in a variety of elected positions and voluntary roles, diligently and selflessly undertaking the work on behalf of the AMA members. Born in Sydney, Andrew completed his undergraduate medical studies at the University of New South Wales and then, after a stint in general practice, trained in dermatology. He commenced specialist practice in Canberra in 1993 and also runs outreach clinics in Young and Moruya. In addition, he has visiting medical officer appointments to both the Canberra Hospital and the Calvary Hospital. Andrew is currently Australian College of Dermatology President and was elected President of AMA-ACT in 2012 for a 2-year term. During his term, he was appointed to the AMA Federal Council and continues to serve on Federal Council. He currently chairs the AMA Medical Practice Committee and has, over an extended period, been involved in a range of matters on behalf of AMA members, including the MBS review and compliance issues. Andrew's contributions to the work of the AMA have been thoughtful and consistent. He has willingly contributed his time, experience and expertise, and being based in Canberra, has often been called upon to assist in person with the work of the AMA. At all times, Andrew has provided outstanding leadership for AMA-ACT, whether as a public advocate, an office bearer or a committee member. His tireless, thoughtless and selfless contributions to the work of the AMA and AMA-ACT are greatly admired. Thank you, Andrew. Associate Professor Susan Newhouse is a long-standing member of the AMA, a highly respected senior surgeon, distinguished ex-Army officer and experienced board director and chair. She is a consultant surgeon in private surgical practice, holds a fellowship of the Royal Australian College of Surgeons, Australasian College of Surgeons, and academic positions with the Department of Surgery and Faculty of Medicine, University of Adelaide. Susan contributes to the highest levels of her profession as a clinician, academic and researcher with subspecialty expertise in the management of melanoma and sarcoma. Susan has also completed an Army career spanning more than 20 years in both the regular Army and the Army Reserve. She has served in Cambodia, Bougainville and Afghanistan, and held the unit command of the 3rd Health Support Battalion from 2007 to 2009, one of the 3 deployable military hospitals to support Army's land forces. Her military service was recognised with the award of Conspicuous Service Cross in the Queen's Birthday Honours List in 2009. She is a long-standing AMA member and was awarded the Australian Medical Association Award, South Australia, for service to medicine in 2011. In 2014, she was elected to the AMA Federal Council as a specialty representative for surgeons and served in this role until 2018. During that time, she contributed her expertise as a member of Defence Health Working Group and was a member and then chair of the Health, Financing and Economics Committee 2016 to 2018. She was an active contributor to the discussions and policy development at AMA Federal Council and AMA National Conference. Memorably, at our 2017 National Conference, excerpts of a play adapted from Susan's book, Not for Glory, A Century of Service by Medical Women to the Australian Army and its allies, were performed to acclaim. Since leaving the Army, Susan has retained a strong commitment to the defence and veteran sector. She is co-patron of the RSL Virtual War Memorial and was appointed to the Council of the Australian War Memorial in 2018. Susan has provided exemplary and faithful service to the AMA and has brought credit to the association for her strong leadership in the practice of medicine. She is a role model for Australia's doctors and most deserving of the award of Fellow Australian Medical Association. Susan can't be here today and will find another time during the weekend to present that to her. I believe it's Sunday morning, but I still would like to, at this opportunity, congratulate Susan on becoming a Fellow of Australian Medical Association. Associate Professor Saxon Smith is a dermatologist who has worked in various clinical roles in public and private hospitals across New South Wales, with the Australian Red Cross Blood Service and as a clinical researcher. In addition to running his clinical practice, Saxon is a staff specialist, dermatologist at Royal North Shore Hospital and a clinical associate professor at the University of Sydney. Saxon served as AMA New South Wales President from 2014 to 2016, during which time he worked tirelessly to represent doctors and patients. His presidency coincided with the federal government's disastrous 2014 health budget, which included the ill-fated proposed co-payment and the decision to radically change the structure of health funding beyond 2017. Saxon was a key spokesman for the profession and chairing a successful GP forum in New South Wales to fight the proposed changes. Saxon was also a prominent spokesperson for AMA New South Wales' Sun Protection Public Health campaign. His groundbreaking research on sunscreen was pivotal in educating consumers about proper sunscreen usage. Saxon's research found that many people were not aware that the sunscreen had an expiry date, that it deteriorates when stored above 25 degrees Celsius, that it needs to be reapplied after 2 hours, and that you need 2 tablespoons to cover the whole body. Saxon has had a profound influence on dermatology over a decade. His contributions to the profession, the welfare of his patients and colleagues are exemplary. Saxon is an extremely worthy addition to the AMA Roll of Fellows. Congratulations, Saxon. Thank you all. The full citations of our new fellows can be studied in the conference handbook. I'm now going to call on Associate Professor Andrew Miller to speak on behalf of all 7 inductees. Please come forward, Andrew.
Thank you, Tony. It's actually a singular honour to be recognised this way by your peers, and I have to say there's a mixture of emotions rising in my breast, pride, but humility too, as I listened to the citations of the other recipients that we've had here this afternoon. I consider myself fortunate actually to be counted amongst their number. None of us have done the things that we do seeking this sort of acknowledgement. It's a matter, I think, of an extension of our personalities. We see the need, we feel the call, and most importantly of all, we've been given the opportunity. And I think we have to acknowledge now the remarkable organisation we're in, the AMA, which actually actively encourages and gives us an opportunity to give something back to our profession. It's really quite extraordinary, the support that we get. And in that regard, I'd like to acknowledge the other members of the Federal Council, the committees and the ACT-AMA board that I've served with people who've been given me wise counsel and support and mentoring through all of my activities here with the AMA. None of us, to quote John Donne, or paraphrase John Donne, I suppose, is an island of itself. And we also need to acknowledge the fact that we're here on this journey because of the support and understanding that we've had from our friends and colleagues, and most importantly our families through the years, as they've lived with our absences, lived with our distractions, and at the same time given us support to be able to do the things that we have done. So I'd like to thank them and also thank you, the AMA family, for this. Thank you very much. Okay.
Thank you, Andrew, and once again, congratulations to all our new fellows. You may now return to your seats, and I invite Bev as chair to resume control of proceedings.
Thank you, Tony, and congratulations to the new fellows. Well, we're going to have another go at the video. We ready to roll? And then after that, we'll have the AGM.
To the AMA National Conference with you in person, but as you may understand, there have been a few national events, and from my perspective, a very fortunate outcome. At the moment, technically, we are in caretaker mode, so it wouldn't have been appropriate for me to fly to visit, but I am looking forward to working with you, and one of my first calls was with Tony Bartoni. So to Tony Bartoni, to all of the executive of the AMA and its Federal Council, thank you for all of your work and support over the last 2 years. There's been no confirmation of the ministry. If I'm asked, I'd be delighted to accept and to continue in health, and for the time being I am continuing, and we'll wait and see, and shortly the Prime Minister will make his announcement, but it is a portfolio I love and on which I'm planning to continue the work that we've done together to date. Now, in terms of that work, let's start with the doctors, the long-term National Health Plan, and then the focus on primary care. In terms of our doctors, we know that what we have seen is that Australia has the finest clinical outcomes in the world. The Commonwealth Fund out of New York ranked us as having the #2 health system and the #1 for clinical outcomes. That's you and your peers and everybody who has worked in the Australian health system to create that outcome. We're #2 because we need to improve equity and access. In particular, that's rural, regional and Indigenous Australia. So that has to be a shared passion going forwards. But as part of that, we were very fortunate to work constructively with both Tony and his predecessor, Michael Gannon, in bringing together the compact between the AMA and the government. That allowed for the re-indexation of Medicare, and in particular, it put us on a very, very strong partnership footing for design of programs going forward. Out of that came the $550 million Stronger Rural Health Plan, and that's about having 3,000 new doctors and 3,000 new nurses in rural and regional Australia over the coming decade. A shared program. That then leads into the broader long-term national health plan, the 4 pillars of which we will continue through the course of this government. First and foremost is primary care, and that's so the first call on budget funds under law is Medicare. And what we see is that growth which is more than just population. It's growth which is driven by investment in new and additional services over and above everything else in Medicare. Will go from $19 billion under the previous government to 26, 27, 29 and $31 billion over the 4 years of the recently announced budget, which we took to the election, which has now been reaffirmed. Linked to that is the fact that we will also be able to continue to support new medicines. 2,000 new medicines to date, life-saving, life-changing. It empowers you to be better doctors, more effective doctors, to help change lives, save lives and protect lives, whether it's or can be for cystic fibrosis, Spinraza for spinal muscular atrophy, whether it's medicines such as Keytruda or medicines such as Tagrisso, so many life-saving, life-changing medicines, particularly as we evolve the nature of medical treatment over the course of the coming decade to greater immunotherapy, greater precision, increased genomics and increased stem cells. That's an exciting pathway and plan. The second of our pillars is, of course, the hospitals. Now, in terms of the hospitals, we're investing an extra $31 billion in the Next Hospitals Agreement. And what we've done is we've gone from $13 billion of hospital funding before we came to government on an annual basis to what will be over the next 4 years, 23, 24, 25 and $26 billion. So an immensely important investment. But linked to that is the reforms to support private hospitals and private health insurance, so Australia has a blended system. We've just had the lowest change in private health insurance in 18 years, but I want to continue to push on this front, to go further, to achieve more, and to ensure that we're strengthening private health as we proceed. And that will mean that we can keep Australia's blended system so as we take the pressure off public hospitals by allowing as much elective surgery as people can pursue within private hospitals. That's a really important Australian model, which I think sets us apart from so many other nations in the rest of the world. And then there are the exciting investments in hospital projects around the country, announced either prior to or during the course of the election. These include the $100 million for the work of helping to create a new Children's Comprehensive Cancer Centre in Sydney. This is a once-in-a-lifetime project. The $80 million for the Peter MacCallum Clinic in Melbourne to work in particular on delivering CAR-T therapy here in Australia, to make this a world-leading site. And that was backed up by the Medicare approval, which was given through the MBS, or Medicare Services Committee, just the day before we went into caretaker. So the facility will be there and the support through government funding. What a profound step forward. Whether it's the Repat Hospital in South Australia and the investment there, or investments around the country, over 87 different investments in particular sites, these will help build facilities on top of everything else. So that then brings me to the third of our pillars, mental health. Now, in terms of mental health, this is a personal passion, not just for myself, but for the Prime Minister. The night of the election, Scott rang me, and at 10 p.m, in the midst of what would otherwise, you would imagine to have been an extraordinary euphoria, he only really spoke to me about one thing. He said, I want to work with you and with the Treasurer on mental health and suicide prevention. That's such a passion of mine. He said to me, at the very moment he could have been focused on other things, that was where he turned his mind. So that's our Prime Minister. And that's a wonderful opportunity to work together. There's a major youth mental health package, a major mental health package, an $800 million additional package. So we work together on that to save lives and protect lives, and in particular to ensure that there's a support for our GPs and our specialists going forward. Moving beyond that, we want in particular to lift the role of preventive health. And I would like to strike a partnership with the AMA and the College of GPs and others to drive forward a national preventive health strategy to achieve change in the way in which we approach healthcare, so as we keep people from getting sick rather than have to simply respond all of the time. And this is what you said to me. And so to Tony and to others, we're not just listening. I've heard, and that is an initiative I would like to take forward beginning today. Then finally, there's medical research, and the fourth of our pillars. Now, we've laid out in the budget a 10-year medical research future fund plan. This is a comprehensive plan which we'll now go about implementing, and that's about the work on patients and the $600 million for what we have in the rare cancers, rare diseases clinical trials programs, but backing that with the $100 million investment in regional clinical trials. Beyond that, there's the researcher-driven program. The first round of frontier science projects have been announced during the course of the election campaign, but as decisions of government. We have the translation programs, and then finally the 8 great national missions which will last a decade each. Whether it's stem cells, whether it's genomics, whether it's brain cancer, whether it's dementia or Indigenous healthcare, whether it's traumatic brain injury or other areas, these are just profoundly important. And it's about transforming the way that primary care is delivered and the changes that can occur. That brings me lastly to our shared agenda going forward, focusing on doctors and nurses and primary care. In particular, we have announced through a shared partnership with the AMA $1.6 billion of additional primary care funding. At its heart is the $450 million program for flexible delivery of primary care, sometimes called universal telehealth, but it's more than that. This is the ability for the doctors to receive a significant payment, to be more flexible in the way in which they're able to deal with their patients, so as you can receive a benefit by talking with patients, whether it's over the phone, in a teleconference, or working with them by text or email, or having them work with your practice nurses. We begin with the over 70s, and I think that's an immensely important step. Allied with that is the $200 million of additional support for practices, the almost $200 million of additional support for bringing forward increased payments for 187 GP items to the 1st of July 2019. And well done, Tony, for never, ever, ever giving up in your advocacy for that on behalf of your constituency. And then that brings me to out-of-pockets. So this is a challenge for all of us. The Chief Medical Officer is leading this program, and we will work together on that transparency. It's most closely aligned with the specialists, but I want to work with you on that issue to ensure that there's greater transparency on out-of-pockets, and that we are able to deal with the outliers whom Tony and others in the profession have said are not reflective of the broad goodwill, skill and capability of the amazing medical profession here in Australia. We did, following up very specifically from an AMA proposal, announced $10 million for compression garments for lymphedema patients in Australia. Along with Teresa Gambaro and Lymphedema Australia, the AMA was the co-sponsor and co-author of that proposal. Finally, I want to look to the deep long term. I'm announcing today that I would like to work with the AMA and the College of GPs on a 10-year primary healthcare plan for Australia. This long-term primary healthcare plan is something I'd like to do with you. We have the parallel with the 10-year MRFF plan. We would look at it in in different waves of reforms, and we can work on this together. It can only work as a shared partnership. But what we've done on the Compact, the stronger regional health plan, and then in particular on the primary care plan, which has delivered $1.6 billion for primary care and $1 billion of that specifically for GPs. So you're doing your work. Now we plan on that decade-long basis. I want to thank you and congratulate you and wish you a wonderful national conference, and I look forward to continuing the work with Australia's amazing doctors and nurses.
Well, we must, that was worth rolling again. We must convey to Minister Hunt our thanks for his address and those announcements which he made, and congratulations to Tony and our office bearers, our advocates. That's a really very substantial set of wins there in response to the pre-election advocacy. We'll now get ready for the AGM, and I ask that the media leave the room. I hope everybody's got their voting cards and have signed in, and I'll invite the chair of the AMA